Hello, everyone. Our today's topic is surgical anatomy and physiology. We have also divided this lecture into two parts. And in this part one, we will be learning about three important topics. And the number one is basic surgical anatomy, in which we will be learning about the head anatomy, neck, thoracic, abdominal, and pelvic regions. In the next topic, we will be learning about the key structures in surgery, that is blood vessels, nerves, and organs. And in the third topic, we will be learning about the physiology of wound healing. These three topics we will be covering in the next part of surgical anatomy and physiology. So, basic surgical anatomy. Now, what is the basic surgical anatomy of head? Now, a head basically it includes neurocranium that we commonly call brain case, or there is viscerocranium that is face, and it is basically supported by a skull that is formed by 22 bones, like the frontal and temporal bones. Now, what does head anatomy includes? It houses the brain and sensory organs like eyes, ears, nose, and tongue, and it features structures like the skull, muscle for expressions and chewing, and the jawbone like mandible. Now, the overall head basically functions as a protective casing and center for sensory processing. Now you can appreciate the pictures here. We will be covering these pictures in the next few slides. Uh, so the anatomy of head basically it includes the bony framework and dural compartments. Now what are bony architecture in the head? It basically has calvarium, it has cranial bases, and it has key foramina. Now, what is calvarium? It is the upper dome-shaped part of the skull that encases the brain, also known as the neurocranium. Now, it is basically composed of the frontal, parietal, occipital, and parts of the temporal bone. Now, here you can appreciate the calvarium. This is the calvarium. This is the calvarium. You can see these are the bones. Like it is a calvarium is basically outer bony cage, and it is composed of the bones like temporal bone, occipital bone, parietal bone, frontal bone. So you can appreciate this is calvarium. Now, then there are cranial base. Now, cranial base is again divided into anterior, middle, and posterior fossa. Now, the thin floor of the middle fossa that we call tegmen tympani is a common site for CSF leak post-trauma. So, whenever there's a trauma and after trauma the CSF leaks, it is mostly from this tegmen tympani part of the middle fossa. Now, then there are key foramina. Now, foramina are important, like you say, holes in the brain or in the head that passes important structures. Like there's cerebral foramina, there's optic canal, superior orbital fissure, foramen rotundum, foramen ovale, foramen spinosum, internal acoustic mediators, regular foramen, hypoglossal canal, and foramen magnum. So all these are important foramina through which important structures from brain to other parts of the body pass. Now, this was about the bony structure or bony architecture. Now we come to the dural layers and sinuses. Now, dura mater is the important layer. Now, dura mater is the outermost, toughest, and most fibrous of the three meningeal layers. That is dura, arachnoid, and pia. Now, these are three important meningeal layers, and dura is the outermost and toughest layer. It has basically two layers. One is periosteal, that is adherent to the bone, and other is meningeal. Now, these two layers basically they split to form the venous sinuses. Now, what are the venous sinuses? Now, venous sinuses are basically they are the dural venous sinuses that are endothelial lined channels. Now, venous sinuses are endothelial lined channels that lie between the periosteal and meningeal layers of the dura mater. Now, these are primarily drainage system for the brain, through which blood drains into the vena cava system. So, they are the primary drainage system for the brain. CSF via arachnoid granulations, because CSF comes into the venous sinuses via arachnoid granulation, and also it they drain the part of the skull that is diploid of the skull, that is spongy layer of cancellous bone. Now, one of important sinuses in our head is cavernous sinuses. Now, this sinus is of paramount surgical importance due to the critical structures they pass through and in its lateral wall. Now, basically, this is a plexiform sinus on either side of sella turcica that is part in the brain. And why cavernous sinus is important? Because it contains the important nerves, important arteries, and veins. Now, it contains basically cranial nerve 3, cranial nerve 4, B1, B5, and cranial nerve 6, the only nerve within the sinus proper, and also it contains the internal carotid artery. Now we come to the cranial nerves and vascular supply of the head. Now, there are total 12 cranial nerves, but the critical 7 for the surgery we must learn and we must understand are these. The one is cranial nerve 7, that is facial nerve, and it is basically it has function of for facial expression. And the key landmark through which you can identify the facial nerve is stellomystoid foramina, through which it passes, and it must be identified and preserved in peritectomy and mystoid surgeries. Now, facial nerve you must be identifying during these surgeries. Other is cranial nerve 10, that is vagus nerve, and it has function for vocal cord function, and it has branches like recurrent laryngeal nerve, and it functions in swallowing and autonomic tone. The other one is cranial nerve 11, that is spinal accessory nerve, and it innervates the sternocleidomastoid muscle, trapezius muscle, and it is nerve that is routinely sacrificed in vertical neck dissection, leading to the shoulder syndrome. Other nerve, the important nerve is hypoglossal nerve, that is cranial nerve 12, and it innervates basically tongue muscles, and it causes the tongue movement. So you must be identifying this hypoglossal nerve when you are dissecting the digestive tendon. Now, what is arterial supply in the brain? There are two important arteries, like internal carotid artery and external carotid artery. Is internal carotid artery, it has terminal branches like anterior and middle cerebral arteries, and the middle meningeal artery from maxillary artery is a common source of epithelial hematoma. So, middle meningeal artery comes from it is the branch of internal carotid artery, uh, because maxillary artery is the branch of internal carotid artery. So, middle meningeal artery comes from maxillary artery, and it is the common source of blood in the epithelial hematoma. External carotid artery, it has basically 8 branches, and you can learn or understand through rule of two, because 2 branches are anterior, like facial and lingual, 2 branches are posterior, like occipital and posterior auricular. So just like these, they have the 8 branches, this external carotid artery. So again, external carotid artery ligation for this artery is an option for control of hemorrhage. Whenever there's a hemorrhage, you must ligate this artery. So you can appreciate these pictures. These are the bases, bones of the cranial base. These are all you can see holes. These are foramina, and these are the cranial nerves you can see. And this is calvarium. Also, this is calvarium. Here you can see also this is facial nerve. This is the course of facial nerve, and this is your vagus nerve, and this is also a cranial nerve 11, spinal accessory nerve, and this is the course of hypoglossal nerve. Now we come to the anatomy of neck. The anatomy of neck, but basically it includes the cervical spine, that is 7 vertebra, which supports the head and protects the spinal cord, and various organs like the larynx, trachea, and thyroid gland. And it is also organized into anterior and posterior triangles by the sternocleidomastoid muscle, and containing crucial muscles, nerves, and blood vessels such as carotid artery that facilitate breathing, swallowing, and movement. So, anatomy of neck basically includes the cervical spine, the larynx, trachea, and thyroid gland. And again, the whole area of neck is divided or organized into the triangles, like anterior and posterior triangles. Now you can see basically neck is some kind of compartmentalized, you say, area or region. So it has cervical triangles. Like the neck is divided into anterior triangle and posterior triangle. Now, when you're reading these triangles, you must identify and learn about the borders of these triangles. Like anterior triangle is bordered by the mandible, sternocleidomastoid muscle, and the midline. And this anterior triangle is subdivided into submental, submandibular, muscular, and carotid triangles. Now, among all these, carotid triangle is the gateway to the great vessels. That is the important triangle in the neck that passes the great vessels into the brain. After this, you have posterior triangle, and that is bordered by sternocleidomastoid muscle, trapezius muscle, and clavicle. Now, what does this triangle contains? It basically contains the brachial plexus trunks, the important nerves for the upper arm or the upper uh, both arms, and they also contain spinal accessory nerve, phrenic nerve that is on the anterior scalene muscle, transverse cervical artery, and supraclavicular nodes. These are all the important structures in the posterior triangle. Now, after these triangles, you will see fascias in the neck. Now, there is deep cervical fascia. Now, the deep cervical fascia is a layer of connective tissue in the neck that compartmentalizes and supports various structures. So it basically is a connective tissue. That fascia is basically a connective tissue that compartmentalizes and supports those structures in the triangle. And it has these layers. It has superficial layer that envelops the sternocleidomastoid and trapezius muscles. It has middle, that is pretracheal layer, that envelops the visceral column like thyroid, trachea, esophagus, and the straight muscles. It has deep prevertebral layer that covers the vertebral column and deep muscles, and it has carotid sheath. Now, so no, what is carotid sheath? Carotid sheath. Now, deep cervical fascia has basically three layers. These three layers. But carotid sheath is different. Different. Now, carotid sheath is basically condensation of all three layers containing common and our internal carotid artery, internal jugular vein, and vagus nerve. So all these layers basically when they contains, they form the carotid sheath. And through carotid sheath, the common or internal carotid artery, internal jugular vein, and vagus nerve, they all pass through it. Now we come to the important structures in the neck like thyroid, nerves, and blood vessels. Now, thyroid gland is the most important organ in the neck, and where you will find a thyroid gland, it is basically found over the isthmus, like second to fourth tracheal rings, and the pyramidal lobes are often present. Now, blood supply is important for the thyroid gland because it is supplied by superior thyroid artery, that is the first branch of external carotid artery, and inferior thyroid artery, that is from thyrocervical trunk. Now, the superior thyroid vein and artery run close to the external laryngeal nerve. That is important point for the surgery because whenever you are ligating the superior thyroid vein or artery, you must preserve the external laryngeal nerve. Parathyroids are again very important structures in the neck. They are usually four and they are on the posterior thyroid, and blood supply is from the inferior thyroid artery. Critical nerves that pass through the neck are situated in the neck are recurrent laryngeal nerve, that is the branch of vagus, a right recurrent laryngeal nerve loops under subclavian artery, and left recurrent laryngeal nerve loops under aortic arch. That is, it runs in the tracheoesophageal groove. So this is important analogy. This is important phenomena you have to understand because right recurrent nerve is under the subclavian artery. So whenever you are injuring the subclavian artery, you will injure the right recurrent nerve, and whenever you are injuring the aortic arch, the left recurrent nerve will be injured. Now the external laryngeal nerve, that is the branch of superior laryngeal nerve, it runs with the superior thyroid artery and it provides the motor innervation to the cricothyroid muscles, like these are the tensors of the vocal cords. So this is the overall anatomy of the neck. You can see here, this is anterior triangle. Uh, in the lateral, you see sternocleidomastoid is basically bordering it in the medial side. There is midline of neck, and the upper part is mandible. This is anterior triangle, and there you can see this is the thyroid gland. You see, and this is the isthmus of thyroid gland, and this is trachea. And there you can see also thyroid gland. These are the triangles, important triangles, and these are basically deep cervical fascia, and these are the layers of deep cervical fascia: nesting layer, prevertebral layer, and carotid sheath in the red you see, and pretracheal layer. Now we come to the anatomy of thorax. Now, thorax or chest is the region of the body between the neck and the abdomen. So it is basically a region between the neck and the abdomen. And it's a bony cage, basically formed by the sternum, ribs, and thoracic vertebra, and they protect vital organs like the heart and lungs. Thoracic cavity also contains other structures like the trachea, esophagus, and the thymus gland and the base and various muscles and nerves. So why thorax is important? Because the heart is found in it. The great vessels are there, and pulmonary arteries and veins, the superior vena cava and the aorta. So these are all the important structures in the thorax. Now, thorax is basically a bony structure. Again, I just told you earlier. So it has the 12 pairs of ribs and thoracic vertebrae, and also they are supported by ligaments and muscles. Now, the muscles of thorax are also important for the vital actions of breathing, and muscles that attach to the thoracic wall may also contribute to the general movement of the trunk, upper limbs, and the knee. So now we come to the anatomy of thorax. So it has basically mediastinal divisions and it has the cardiac relation. Now, what are the mediastinal compartments? They are crucial for the differential diagnosis. It has basically, like you say, four compartments: superior compartment, anterior compartment, middle compartment, and posterior compartment. I can show you this the picture. There you see this is posterior compartment of the thorax, and this is the anterior compartment. Sorry, this is posterior compartment. This is anterior compartment, and this is middle compartment. So that superior compartment basically it is above the external angle like T4 or T5, and what does it contain? It contains the brachiocephalic veins, aortic arch, trachea, esophagus, and thoracic duct. What is in the anterior compartment? It is basically between the sternum and the pericardium. It contains thymus, remnant, fat, and lymph nodes. In the middle compartment, you find heart and pericardium, great vessels and phrenic nerves, and posterior is basically behind the heart, and it contains the structures like esophagus, descending aorta, azygous vein, thoracic duct, and vagus nerves. Now, heart and pericardium are the important structures in the thorax. Now, pericardium is basically a fibrous sac which contains the heart. So, the phrenic nerve basically it runs laterally, and it must be identified during pericardial window. So, phrenic nerve basically it runs laterally like between fibrous pericardium and mediastinal pleura, and it is important nerve that must be identified whenever you are opening the pericardial window. Surfaces like the sternocostal muscle, sternocostal surface is onto the right ventricle, the diaphragmatic surface is on the left ventricle and right ventricle, the base is on the left atrium. Coronary arteries, which supply blood to the heart itself, are left anterior descending artery is the important artery that supplies blood, and it is in the anterior interventricular groove. Now we come to the important structures like ribs in the thorax and the pulmonary hilum. Now, the bony framework are the ribs in the thorax are basically, as you all know, there are 12 pairs of long curved bones that form the protective thoracic cage. Now, they articulate posteriorly with the thoracic vertebra. So there you see there are the 12 pairs of long bones, and posteriorly they have the thoracic vertebra. Internal costal spaces contain muscles, nerves, and vessels essential for breathing. Now, the pulmonary hilum. So pulmonary hilum is basically the root of the lung. You call it root of the lung. So there are two hilums in the lung. The right lung has the right lung hilum and the left lung hilum. So when you see the structures of, how they pass in the right lung hilum, you see epicardial arch bronchus, then it runs into the pulmonary artery, then the hypartial bronchus in the pulmonary veins. In the left lung hilum, The sequence is like pulmonary artery comes before main bronchus, then pulmonary veins. So this is surgical mnemonic like RALS that is important when you are doing surgery on the lungs. Uh, You see in the right lung, the pulmonary artery is always anterior to the bronchus. And in the left lung, you see pulmonary artery is superior to the bronchus. So this is basically the fundamental rule for safe dissection during lobectomy or pneumonectomy of the lung. So there you see, these are the 12 pairs of ribs. These are the compartments. There you see the important structures like lungs and also the heart and other structures like blood vessels. There you see this is the vena cava. This is the heart and pericardium. Now we come to the anatomy of abdomen. Now abdomen is the body region between the chest and pelvis, and it basically houses the organs of digestion, urinary, and immune system, like the organs stomach, intestines, liver, kidneys, and spleen. And abdomen is basically protected by abdominal muscles, and it is bounded by the diaphragm superiorly and the vertebral column posteriorly and the bony pelvis inferiorly. So, if you see the abdomen, you will see that superiorly it is lined by diaphragm or bounded by diaphragm. Sorry, on in the posteriorly you see it is bounded by the vertebral column, and in the inferiorly it is bounded by the bony pelvis. Now, organs are held in place by connective tissue sheaths like the peritoneum and mesentery, which also provide blood vessels and nerves. Now, abdominal anatomy basically you have to see what is abdominal wall and how the blood supply in the abdomen is derived. Now, you see, abdominal wall is very important and it has many structures. Like whenever you are doing surgery on abdomen, you must go through all these structures or all these layers. So, abdominal wall basically consists of layers like the first will come skin, then comes the campus fascia, Scarpa's fascia, external oblique muscle, internal oblique muscle, transverse abdominis muscle, transverse fascia, peritoneal fate, and then you enter the peritoneum, and there you have the organs. Now, the neurovascular bundle that is in the abdomen, it runs between the internal oblique and transverse abdominis muscle. You have also inguinal canals in the abdominal wall, like Hazelbeck's triangles, from which the direct hernia comes, or deep inguinal ring from which the indirect hernia comes. They are also part of the abdomen. Now, foregut in the blood supply from to the foregut comes from celiac trunk. When you see stomach, it is basically supplied by left or right gastric, left or right gastroepiploic arteries, and short gastric arteries. In liver, you see important triad like porta hepatis. In this order, like the hepatic artery will be on the left, common bile duct will be on the right, and portal vein will be posterior to all this. So porta hepatis in the liver is important, like landmark you see. Then there is Cantelli's line that divides the right and left lobes in the liver. Duodenum, you see, the first part is intraperitoneal and it is mobile. The second part is retroperitoneal and contains the ampulla of water. Now, again, the intestinal blood supply, and then we will be reading about the retroperitoneal organs. So, mesenteric blood supply, like midgut, it is supplied by the superior mesenteric artery, and midgut starts from duodenal jejunal flexure, that is ligament of Krebs, to proximal two-third of transverse colon. Hindgut, it basically starts from distal one-third of transverse colon to upper rectum. You have important artery in the midgut, that in the abdomen, that is marginal artery of Juman and arc of Rheolon. They are basically collateral connections between superior mesenteric artery and inferior mesenteric artery. Whenever you're ligating IMA, inferior mesenteric artery, like in the abdominal aortic aneurysm repair, must be ligation must be distal to the left colic branch, like to preserve the collateral flow and prevent colonic ischemia. So whenever you are repairing the abdominal aortic aneurysm, you will be ligating the IMA, but ligation must be distal to the left colic branch. Because if you are ligating proximal to the left colic branch, then you are basically disrupting the collateral connections and it will cause colonic ischemia. Now, the retroperitoneum. So, in layman's language, you call it surgical no man's land because the surgeon can't go there. And it has structures like aorta, inferior vena cava, kidneys and ureters, pancreas, except like tail, duodenum, and second, fourth parts. So, this retroperitoneum are basically behind the peritoneum. So due to the Koch's maneuver, it is a maneuver that mobilizes the duodenum and pancreatic head by incising the lateral peritoneal attachment. So you also do the cattle Brad's maneuver for the right colon. So this Kocher maneuver basically it is a maneuver that highlights or identifies the retroperitoneal structure. Ureters, they are the critical landmarks. They cross the iliac vessels at the bifurcation in males. They pass under the vas deferens. So this is the Couch's maneuver in which you basically identify or highlight the retroperitoneal structures. So this is basically abdomen. There you see these are the intraperitoneal inside the peritoneum, retroperitoneal behind the peritoneum, and mesentery is basically double layer of distal peritoneum. These are the viscera in the abdomen, and these are the muscles in the abdomen. Now we come to the anatomy of pelvis. Now pelvis is basically a basin-shaped skeletal structure that connects the trunk to the legs. So it is important because it connects the trunk to the legs, comprising and it comprises of a sacrum, coccyx, and two hip bones, like each formed by the fused ilium, ischium, and pubis. Now these three bones fuse to form the hip bone. Now, it functions to support the trunk's weight and transfer forces to the lower limbs, protect the abdominal and pelvic organs, and provide attachment points for muscles of the trunk, legs, and pelvis. So, key joints basically in the pelvic region are pubic symphysis, that is anterior, to sacroiliac joints, that is posterior, and the sacrococcygeal joint, that is also posterior. Look at it. Now, in the anatomy of pelvis, you must be understanding the pelvic side wall anatomy. Now, what is the important vasculature in the pelvis? What is innervation in the pelvis? And what are the lymphatics? In the vasculature, you see common iliac artery is important artery, and it bifurcates at the sacroiliac joint. It is also internal iliac artery that supplies the pelvis and it divides into anterior, that is visceral, and posterior, that is parietal divisions. And it has key branches like superior vesical artery, uterine artery in females, middle rectal artery, and internal pudendal artery. Innervation in the pelvis comes from sacral plexus, like it is the nerve roots of L4 to S4. Sciatic nerve is the most common nerve from the sacral plexus that supplies the pelvic entire wall and structures. Autonomics like superior and inferior hypogastric plexus, they are also located in the pelvis and they control erection, ejaculation, and bladder detrusor functions. And other is nerve to obturator internus, and it runs on the pelvic side wall lateral to the plexus, and it is a key landmark to identify the plane for nerve sparing dissection. So that region is basically important when you have to uh, spare this nerve to obturator internus. Lymphatics, which drain the lymph in the body, they basically follow arteries like key groups like obturator, internal iliac, external iliac, and common iliac and presacral. Now, what are the important pelvic organs and what are the avascular planes? Now, pelvic viscera are basically importantly, you see bladder is there, rectum you see there, and in the male you see prostate and the female uterus. Like bladder basically it lies behind the pubic symphysis. And the ureter, that is the remnant of the dome of the umbilicus, and that is also found in the pelvic region. Rectum, that is, you see, it follows the sacral curve, and it has no true mesentery, and but it is surrounded by the mesorectum, that is envelope of fat, vessels, and lymph nodes. In the male, you see prostate apex that sits on the urogenital diaphragm. So prostate is basically on the urogenital diaphragm And then you see the non-bilious fascia that separates prostate from the rectum. That is important fascia. In the female, you see uterus that is supported by broad, round, and the uterosacral ligaments. Ovarian vessels run in the infundibulopelvic ligament. Avascular anatomical planes, these are the holy planes of pelvic surgery. So now what are these? These are natural membrane-lined spaces within the body that surgeons can safely enter and dissect to create a working space. So these are important spaces for surgeons whenever they are doing surgery in the pelvic region during pelvic surgeries like rectal cancer operations. Now these are important spaces they can create and perform surgeries like retropubic space of Regius that is between bladder and pubic bones, pararectal spaces that is, they are lateral to the mesorectum, presacral spaces these are between mesorectum and sacrum, and it contains presacral veins they can bleed torrentially if injured. Rectovaginal or rectovesical spaces these are between rectum and vagina or prostate. So there you see, this is the pelvic anatomy. You see, these are the pelvic structures. These are the bones, and there you see these are important organs, and these are the important muscles. Now, what are the key structures in surgery, like blood vessels, nerves, and organs? For the blood vessels, you must understand the arterial anatomy and then the venous anatomy. If you see arterial anatomy, the structural layers like tunics of the artery, they have intima, they have media in which muscle is located that determines the vasoconstriction, and they have adventitia that is outer layer. So overall, the blood vessel or the artery is basically has three layers: intima, media, and adventitia. Surgical classification for the arteries is very important. There are three kind of arteries. One are elastic. They have large conduit like aorta, carotids, and they basically hold suture very well. But again, they are prone to atherosclerosis. There are muscular arteries. They are important in the distribution. They are like femoral and brachial, and they are common sites for the bypass graft. Bypass grafts are basically taken from these arteries. And then there are arterioles, and they are the important structures or arteries that create the resistance. So they basically control the flow and pressure in the arteries. Sorry. Anastomotic networks like collateral circulation, there you see a cycle of villus in the brain, marginal artery of Drummond in the abdomen, genicular anastomosis in the knee. And they basically, these are the collateral circulations, and they provide alternative pathways if a main vessel is active. And arteries like central retinal artery branches, and the occlusion of these leads to tissue necrosis. Now, blood vessels, uh, you must understand what is this was about the arterial anatomy. Now we come to the venous anatomy, and it is basically a low pressure system. So you must understand the differences from arteries. The veins basically have thin walls, and they have less smooth muscles, larger diameter, and they have the presence of valves. That is important point to remember because they ensure unidirectional flow, and they have low intraluminal pressure, which makes them more prone to collapse and air embolism. Systems like there are important three systems: superficial veins, deep veins, and portal system. Superficial veins like great saphenous vein that drains to femoral vein, cephalic, basilic veins, and again these superficial veins are common for harvesting a bypass conduit or IV access. Deep veins, they are paired with arteries like the femoral, popliteal, and brachial artery, and they are primary conduits for the venous return. Portal system that drains the GI tract to liver, that is portal vein. It is formed from superior mesenteric vein and splenic veins. Nerves, uh, what is the anatomy of nerves, structure and repair? So if you go through the macroscopic anatomy of the nerve, it has neuron, that is cell, body or axon. It has support cells like Schwann cells that produce myelin, and that is insulation for the fast conduction. They have endoneurium and which surrounds the individual axons. They have perineurium that surrounds the fascicle functional unit, and they have epineurium the outermost sheath. Now, there's also the classification of nerves. There are some motor nerves, there are some sensory nerves, and there are some mixed nerves. Motor nerves basically they have end plate and which basically causes the muscle contraction. So motor nerves cause they basically cause the muscle contraction. Sensory nerves they carry touch, pain, temperature, and proprioception, and mixed nerves they carry both functions like motor and sensory. And the most major peripheral nerves are mixed, like sciatic and median nerves. These are mixed nerves. Now, key peripheral nerves with their vulnerabilities in testing, like in the upper limb, you have three important nerves, like radial nerve, and it spirals around a humeral shaft. So it is vulnerable in humeral fracture, and whenever there is injury to radial nerve, there will be a wrist drop. The person cannot hold the wrist, so the wrist will be dropped. Ulnar nerve, it basically it is behind the medial epicondyle, that is we call funny bone, and its injury causes claw hand and sensory loss to fourth or fifth digits. Median nerve, it runs through carpal tunnel, and its injury causes ape hand, that is the loss of thumb position. In the lower limb, you have sciatic nerve, and it basically exits pelvis where greater sciatic phenomena, and its injury causes the foot drop and loss of hamstring function and common peroneal nerve. And it basically for loss of hamstring function. Then there you have a common peroneal nerve, and it wraps around fibular neck, and that is extremely vulnerable to compression, trauma, or poor positioning, and its injury causes foot drop. Now we come to the organs. In the body, you have solid organs. If you go through the macroscopic anatomy, the solid organs will be having parenchyma, that is functional tissue. Like in the liver, you see hepatocytes, and in the kidney, you see nephrons. Stroma is supporting connective tissue frameworks, and they have the segmental anatomy. Like organs are often divided into functional segments based on vascular supply. Like in the liver, coinoid segments and renal segments. Key solid organs and characteristics. The key organs in the body are liver. It is dual blood supply, portal vein 75% and hepatic artery 25%. And liver has a remarkable regenerative capacity. Spleen is again highly vascular lymphoid organ, and that it has a fragile capsule. Kidney has the nephron, and they are usually vulnerable to ischemic injury. Then you have the hollow organs, and they are basically layered wall structures inside to out. In the hollow structure, you see mucosa, that is secretory or absorptive layer. You see submucosa, that is the strongest layer, and it holds the sutures for base for the anastomosis, and it contains the mucinous plexus, muscularis propria, inner circular and outer longitudinal muscle, and it contains the orbex plexus. Then you have the serosa or adventitia, that is the outer layer. And key hollow organs are basically esophagus, the stomach, small and large intestine, gallbladder, and urinary bladder. Now we come to the physiology of wound healing. Now, in the wound healing, basically, wound healing is a complex, dynamic process of replacing the devitalized or missing cellular structures and tissue layers. So it is basically a process of replacing that damaged layer or structure in the skin. So there are two main types. The wound healing can occur through primary intention, and it can occur through secondary intention. In the primary intention, it is basically done in the healing of clean and approximated wounds like surgical incision, and it has minimal granulation tissue. In the secondary intention, in which the healing of wounds with tissue loss or contamination is basically done where edges cannot be approximated, then the secondary intention wound healing is done, and it has significant granulation and contraction. Now there are four overlapping phases. There are four phases for wound healing. The one is hemostasis, that is immediate. Other is inflammation, proliferation, and remodeling. Now, the phase one is hemostasis and the inflammatory cascade. In the phase one, there are key processes like vasoconstriction, uh, the immediate neurogenic response to limit blood loss. Then there is platelet plug formation. So the platelet adhere to the exposed collagen via von Willebrand factor. So whenever there is a damage to skin, so the platelets basically they are exposed to the collagen via von Willebrand factor, and they become activated and aggregate, and this forms a temporary plug. Coagulation cascade is then initiated, and it is basically like thrombin converts fibrinogen to fibrin that forms a stable clot that scaffolds the wound. Now, that clot that is formed, it acts as a signaling center. The fibrin clot releases the key growth factors and cytokines like PDGF, TGF, beta from trapped platelets, which actively recruit cells for the next stage. The next phase is phase of inflammation, that is cellular debris and defense. And key cells in this phase are basically neutrophils and macrophages. Neutrophils are important in the first 24 to 48 hours, and they are recruited by the complement and cytokines, and they phagocytose the bacteria and debris. Also, they release the proteases for cleaning. Macrophages, they basically come after day three, and they are the orchestrators of healing, and they phagocytose the remaining debris, apoptotic neutrophils, and bacteria, and they secrete a vast array of growth factors like PDGF, FGF, TGF beta that stimulate the next phase, that is proliferation. Now, clinical signs are very important during this phase, the phase of inflammation. You see in the wound these three signs, uh, four signs basically: the rebore, that is redness; tumor, that is swelling; calor, that is the heat; the wound plug or that wound will be warm; and dolor, it will have pain. So this is a normal and necessary process. Wound healing, the phase three, that is the phase of proliferation, rebuilding the framework. Now, in the proliferation, there are big three processes. That is, number one is angiogenesis, the other is fibroplasia, and the third one is epithelialization. Now, in the angiogenesis, there's the formation of new blood vessels from endothelial cells, creating the characteristic granulation tissue that is deep red and granular in the appearance. In the fibroplasia, fibroblasts are basically recruited. They proliferate and deposit the extracellular matrix, primarily type 3 collagen, and this provides the strength and structure. In the epithelialization, the keratinocytes from the wound edges migrate across the most moist wound bed to form a new barrier. So, in the phase three, that is the phase of proliferation, the wound contraction occurs. So, myofibroblasts contract, they reduce the wound size, and that is critical for healing by the secondary intention. In the phase four, that is the phase of remodeling and maturation and strengthening. The key processes in this phase are very basically the collagen remodeling. That collagen type 3 basically now, sorry, that collagen type 3 basically now converts into the, or it is replaced by the type 1 collagen, that is the stronger collagen. And also the cross linking of these clots and these, like you say, fibroblasts and all that has formed. The cross-linking of all these structures basically happens in the phase four. The collagen fibers become organized along lines of tension, increasing the tensile strength. Also, there is reduction in the cellularity, apoptosis of fibroblasts, macrophages, endothelial cells. It's very necessary. The scar becomes less vascular and the more pain. Now, how strong is that scar? That is the timeline of strength is basically by the week three, they have the 20% of original strength. By week six, they have the 50% of original strength, and after months, the healing are basically the scars plateaus at the 70 to 80% of original tissue strength. Now, what are the factors that affect the healing and what are the modern adjuvants? Local factors that impede the healing are ischemia, that is most critical, infection, foreign body, hematoma, tissue necrosis, radiation, and edema. All these basically they uh, basically stop or impede the healing. Systemic factors, those who impeding the healing are malnutrition, especially protein and vitamin C deficiency, diabetes mellitus, glycosylation of proteins, there is microvascular disease, immunosuppression, like the patient is taking steroids and chemotherapy, advanced age, smoking, and vasoconstriction, and carbon monoxide binding. Now, what are surgical adjuncts to promote healing? What you can do to promote healing? You should be giving negative pressure wound therapy, that is, it manages exudate, increases perfusion, and promotes the granulation. You should be using advanced dressings like hydrocolloids and alliginates foams that maintain the moist environment. You must be giving the growth factor therapy, that is becapellarum, that is PDGF for diabetic ulcers, and also you should be using skin grafts and flaps. That these bring new blood vessels, blood supply to the wound. Now, this was all about the topic. Now we come to the clinical scenarios uh, that can come from these topics or these important texts. Number one is a 55-year-old man undergoes a total thyroidectomy for a multinodular goiter. Post-operatively, he speaks hoarsely and has a weak cough. Which of the following nerve is most likely injured? So he the patient is going thyroidectomy and he speaks hoarsely and is a weak cough. So which nerve you think? So the nerve will be recurrent laryngeal nerve because whenever there is a damage to recurrent laryngeal nerve, the patient speaks hoarsely. A patient has a deep contaminated wound on the heel from a puncture wound that is being managed with a wet to dry dressing. The wound bed is now filled with red granular tissue. Which phase of wound healing does this tissue represent? So the granulation tissue basically forms in which phase? In which phase of wound healing? It forms in the phase of proliferation. A medical student is observing a craniotomy for a pituitary tumor. The neurosurgeon notes that the importance of the lateral wall of the venous sinus, stating this is a neurological jewel box. You must identify the nerves here from a top to bottom. The surgeon is most likely referring to which sinus. The important sinus in the head is basically cavernous sinus. A 65-year-old man with a peripheral arterial disease undergoes a below knee amputation for gangrene. On post-operative day 10, the wound is clean but has not significantly decreased in size. The wound bed is filled with moist, red, granular tissue. Which of the following process is most actively occurring at this point? So, what is basically occurring at this point? Because again, this is the phase three, that is proliferation phase, or deposition of type 3 collagen is basically occurring. In the clinical scenario 5, during a radical prostatectomy, the surgeon emphasizes the importance of dissecting the holy plane to avoid causing impotence. This plane is located between which two structures? So we are talking about the holy plane, and the only holy plane I can see is the mesorectal fascia and the perisacral fascia. A general surgeon is performing a laparoscopic right hemicolectomy. During vascular ligation, the surgeon must identify and preserve the collateral connection between the superior and inferior mesenteric arterial systems to avoid ischemic colitis. Which of the following measures is the most important collateral pathway? So, in the abdomen, you see, you must be having the collateral pathway of marginal artery of June. So, this was all about part one of surgical anatomy and physiology. And in the next part, we'll be reading about those three next topics. And these are the references from which I have taken the text and images. Thank you.